from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio. This is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about asthma for pediatric patients. Our guest today is Dr. Azima Khan, a pediatrician with First Physicians Group here in Sarasota. Dr. Khan, thank you so much for joining us.
Thank you for having me.
What exactly is asthma?
So asthma, if you really want to look at it, it is an episodic and reversible airway constriction and inflammation. And it is in response usually to some kind of infection or an irritant or an allergen. So it is related to the airway, and it can present in different ways. And some people wheezing, they call that. Some people with a chronic cough, or some people having issues with breathing with respiratory infections.
What exactly causes a person to have asthma?
So that's really complex because it is a complex immune-mediated process. And it also involves a person's genetic predisposition and their response to the irritants around them. So if you look at different studies, they've shown that there are three major phenotypes of asthma. And they can be put into early transient intermittent asthma, and typically is seen in children less than 3 years of age and resolves by age 3. And these kids, particularly would present with multiple episodes of wheezing, and the risk factors that are involved in these kids presenting with these recurrent symptoms are either exposure to smoking in utero by the mom, early exposure to smoking later on, early childhood, prematurity. Sometimes, so these kids are more prone to presenting with these symptoms, or even sometimes daycare exposure, again, infections, early infection exposure. So that's the early transient type. The second phenotype is called a non-atopic type, in which they have symptoms with recurrent wheezing between 2 and 3 years of age they start, and that's mostly in response to viral infections. So anytime they have a viral infection, they'll present with wheezing. But most of them, those symptoms resolve early childhood, except children who get infected with RSV, and it is severe, then they can have these symptoms progress into later on in life. And the third subtype that we see in asthma is the atopic type, which is allergy-mediated, or in those patients we see family history of asthma, allergies, and eczema. They have a genetic predisposition to having more allergic response in these kids. And you have a significant IgE response, and you have these wheezing symptoms, and a lot of these kids will have these symptoms extending into later on in life.
How common is asthma?
It's a pretty common disease. So it is one of the most common chronic illnesses of childhood. And its prevalence in the US population is about 7 million US children have asthma. And it accounts for about 750,000 ER visits each year. And it is one of the top 3 diagnoses for admission to the hospital. Wow. So it is pretty common. And also we see asthma more common in lower socioeconomic settings. Also, it is more common in African American children as compared to Caucasians. So the highest initially, they're seen it in Puerto Rican children. But in the last couple of years, it's the African Americans who have the most prevalence of this disease, followed by, again, the Hispanics, then Native Americans, Asians, and then Caucasians.
Is there any way to prevent your child getting asthma altogether?
So again, like we talked about, there are so many things that can trigger it. So like we talked about the early exposure. So there's a hypothesis which is called a hygiene hypothesis. So in developed countries, they've seen that most of these kids, because they are exposed to infection before, and their response to infection is making antibodies and not going the allergic route. So those kids typically don't have as much allergic asthma or progression into later on in life. In developed countries like ours, we have a lot of time exposure to things like molds, dust mites, allergens like pollen. So those things kind of instigate more allergic response. So when you have a young child, and if you definitely have a family history of either asthma or allergies, so it's a good idea to have an allergy-free home to decrease that kind of exposure. So things like candles, incense, wood burning, charcoal burning. So all those things can be triggers that if you're exposed earlier on, that can cause an allergic response and maybe increase your risks of having those kind of responses. Obviously, outdoor allergens you can't control much, like grass, trees, pollen. But again, dust mites are the most common indoor allergens. So keeping your house dust mite free as much as possible. So those are the things that can decrease the predisposition, if you have a predisposition, to get into that. Other thing which is important is, as we've seen, that RSV can cause more issues with later on having more progressive wheezing if you're exposed to it earlier on. So the RSV vaccine is available for younger children, especially if they're premature, you have a family history, so that would be a good way to decreasing that exposure. And then influenza vaccine yearly. So influenza, and they've seen RSV to present with more severe symptoms in people who are predisposed, and then progressively worsening symptoms or more hospitalizations, or they have seen more ICU admissions when you have rhinovirus C, parainfluenza, and RSV infections. So again, trying to decrease the exposure to these things can help you prevent the predisposed people.
And then also, you mentioned before, smoking.
Oh my gosh, smoking during pregnancy, during early childhood exposure is a big thing. Even marijuana, even e-cigarettes so a lot of people think that e-cigarettes, because you're not actively using the smoke cigarette. This is a liquid form, but again, that is also known to increase exposure and risk of asthma and even recurrent ear infections in children.
Oh, okay. Yeah. So what are the symptoms parents should be on the lookout for? Maybe they have a young one at home.
Well, mild coughing with runny nose, cough and congestion are common. But if the child is having trouble breathing with it, meaning you're seeing episodes where they just can't stop coughing, or if they're a toddler and they just want to sit down and not run around and play. So that's another way of them saying, when they're running, they're having trouble breathing, they want to sit down. So if you're having those kind of symptoms, and especially if you have a family history, then you should be on the lookout for asthma.
Is there an age range when asthma is most typically diagnosed?
So most of the time we don't diagnose asthma in children less than 2. Because, again, as we said, it could be viral-induced wheezing. It could be irritant-induced wheezing. So they are called recurrent episodes of wheezing, and it's not diagnosed as a reactive airway disease or asthma as such. But typically after age 3, if you're continuing to have these symptoms, and they're exacerbated by either irritants, allergens, or infections, then yes, they can be diagnosed. But the earlier diagnosis is mostly a clinical diagnosis because of the symptom presentation.
And how exactly is asthma diagnosed?
All right. So again, like we talked about, preschoolers, it's a clinical diagnosis. So they're presenting with coughing or wheezing. When you examine them in the office and you see those are the symptoms and their response to the bronchodilator. So that's a classic response right away. So you do a nebulizer treatment with a bronchodilator, which is a albuterol that we use in the offices, and you see a quick response. And right there, they have reversible airway obstruction.
Got it.
And that diagnoses the wheezing improving with that. But then when you see recurrent episodes, then it is seen that, okay, yeah, this could be asthma. Now, in older children, which are 5 years and older, office spirometry is done, and that's a gold standard for diagnosing asthma. And seeing, you can even do a reversibility test, meaning you do it during when they are slightly sick, and then you give a nebulizer and see if there is improvement with that. There are other methods now which are there, which is really good. There's a fractional excretion of nitrous oxide, which is excellent for measurement of inflammation. And because spirometry does not detect inflammation, it just detects the obstruction in the bigger airways, not even the smaller airways. So this detects the fractional excretion of nitrous oxide, is a more specialized test. Mostly pulmonologist offices will carry it, not a regular, pediatrician's office. And that detects the inflammation, and you can follow patients who have persistent asthma and their inflammation up and down, and basing their treatment on that too. Oh. So that's another test that is available.
Is it possible for children who are diagnosed with asthma young to grow out of it?
So again, it's a yes and no. So let's say if it's a 3-year-old and had episodes in the past of wheezing, had an infection and wheezed, that 3-year-old, if he doesn't have a history of atopy or allergic response, may grow out. But then if you have a history of family history and you have other IgE-mediated immune responses, then likely not.
So you mentioned some of the ways asthma is treated. How is it typically treated?
So typically it is dependent on the kind of asthma we have. So we talk about either an intermittent asthma episode in which these children present maybe once or twice a year with wheezing, and they have symptoms that respond very well to a short-acting beta agonist, which is like albuterol. And they're managed at that point in time, and sometimes they're introduced with also inhaled steroids. Other variety is called persistent variety, which could be more persistent symptoms. So they have symptoms more than twice or thrice a year, and they have either mild, moderate, or severe. And the treatment, again, is there are strict guidelines for treating with it. So you start with short-acting beta agonist, which improves opening the airways right away for you. So you feel better with the breathing. The next step in therapy is an inhaled corticosteroid, which decreases the inflammation, so decreases the secretions and helps you, again, breathe better. And there are other modalities like long-acting beta agonists, which cause airway, again, dilatation, but for longer period of time, but they're not acute rescue medications. And so those are mainstays. And then there are other things like IgE-mediated. Then you have anti-allergies, leukotriene inhibitors that are used. So again, there's a stepwise therapy, and it depends on the symptoms of the patient. And now in persistent or severe asthma, we have immune therapy, which is available as well. And there are monoclonal antibodies that are used too. But again, that is for more severe or persistent asthma, and then they have to be under care of a pulmonologist.
Do most children with allergies require more regular follow-up with physicians than other children?
Yes. So one of the things with asthma being a chronic illness, if you have allergies that trigger your asthma, okay, and you're coming in and we're seeing, okay, dust mites are triggering your asthma, some kind of pollen is triggering your asthma, mold is triggering your asthma. So in that case, you want to get tested. If your symptoms are more persistent, you need to get allergy tested, and you can get immunotherapy for that. So then again, it's going to decrease the amount of episodes of asthma you're going to have. It's going to improve quality of life, and it's going to let you not miss school, be in sports, and do everything. So you need to have a regular follow-up. And the guidelines basically are, as you're doing step therapy and managing their asthma, they should have follow-up every 3 to 6 months, depending on the severity of their symptoms.
Does steroid use in asthma cause issues with growth or other issues?
Yeah, okay. So that's a very common question. A lot of parents have concerns about it. So oral steroid use can obviously cause these issues with blood sugar regulations, bone osteopenia. It can cause issues with cataract and growth issues as well. And those are usually chronic oral steroid use. Inhaled steroids, and the way they are made because of the size of micrograms and the molecule size, they're not absorbed as much in the systemic circulation. So the mode of delivery is as such that it should not have that much absorption. So we've seen kids in studies have shown that children who have chronic persistent asthma, who are on inhaled steroids for years at a time, the only difference in height they've seen is maybe a 0.3 centimeter change in height, adult height, because of that, which is very insignificant as you compare to see for quality of life and control of symptoms.
Speaking of quality of life, I think as a parent, if your child is diagnosed with anything,
yes,
it's terrifying.
Mm-hmm.
So I'm sure you see a lot of parents who are terrified to get an asthma diagnosis. What does that mean for my child? Quality of life wise,
yes,
these children go on to live relatively normal lives, correct?
Yes. So important part in asthma is asthma education. So if you educate the family and the patient about what asthma is really about, how they can be in control of these symptoms, and what they can do on their side to manage the symptoms, it really takes a lot of that stress off of them.
Yeah.
Younger children, yes, they cannot be involved as much in their own care, and the parents have to do more. As they get older, so there are a lot of tools that we use in the clinical settings. So there's a form that we use, it's a questionnaire, very easy, and parents know how to use it, and then they can figure out how to go through it. It's called Asthma Control Test. It's a questionnaire. It checks their response to their medication use, how often they needed to use it in the last 4 weeks. If there's a certain score, it means they need to up their therapy. If there's a certain score, that means they're doing fine. So that's something that parents can use on a regular basis for children who, again, are younger. Also, there is something called peak expiratory flow, which is a small device, handheld device, and there's a number for each age because the lung volumes change with each age. So let's say there is an 8-year-old kid, and you show them how to use it, and their green zone, which is where they're doing good and they don't have any symptoms, and their personal best is, let's say, 250. Okay. Now you do an asthma action plan for them, in which 250 is their goal number, and that's a green zone for them. So they're not using any inhalers, they're doing fine, and they're stable if they have intermittent asthma. Yellow zone, you're going to say, okay, so if your number goes below 200, then and you have some cough, you need to start using your short-acting and your inhaled steroids. Okay, if you've been using it and you're not getting better, then you need to call. Red zone is where they are less than 150, let's say. I mean, it's calculated according to each of their things. And at that time, you're using your short-acting albuterol inhaler, 2 to 4 puffs every 15 minutes, and you're going to the ER. Mm-hmm. So again, this gives them kind of more control of what they're seeing and how they can manage it. So asthma action plan is really important. And then older children and teenagers, usually if they know how to assess this, because sometimes the peak expiratory flow values fall down even before they start with the cough and congestion symptoms. And they can know their personal best. And if they're doing it once or twice a week after, when they're fine, they have an idea and they can say, oh, you know what, it went down. Let me go ahead and start my controller medication. So there are a lot of tools available, and asthma education and the plan for the family, the patient, and the physician to work together is important. And then your point about regular follow-ups, because it is a stepwise therapy. So if you follow up once a year and then you end up going to the ER 4 times in between, it defeats the purpose. So right. you want to prevent them being that sick that they have to go to the ER.
What are the long-term side effects of uncontrolled asthma?
Yes, so it is really important that we prevent what we call is deterioration in lung function, because every time that you have a major exacerbation of asthma, because of the inflammation, there's remodeling of the lungs. So remodeling means then each of your airways goes down into smaller airways, and then in the end you have a alveoli in which the exchange of oxygen and carbon dioxide from the blood happens. So each time there's remodeling, you're losing a lot of those alveoli. And in long term, that's going to cause decreased lung function, can lead to COPD as you get older. So it's really important to pay attention to it and control those symptoms.
And like you said, avoid those hospitalizations, of course.
Yes.
What is your take-home message for parents and patients about asthma?
Okay, so what I would say is if they're having recurrent symptoms, make sure that they follow up regularly with a pediatrician or their physician, whoever they're seeing, and avoid just going to the urgent care or ER every time, because they're not going to have the continuity of care. They're just going to have acute management and never get to where they can figure out what the triggers are, if they need to see an allergist, if they can have allergy therapy, immunotherapy, so that way they could reduce these symptoms altogether, and come up with a plan for managing it better. So that's really important. Then also it is important to ask questions about it. A lot of people have concerns, they're scared about steroids, like you asked the question. Like, most of the patients, when you talk about steroids, they say, well, I don't want my kid on steroids because then they're not going to grow and they're going to have all these side effects. But not realizing there are different kinds of steroids and how you're using them matters as well. So it's important to understand that chronic cough is not always asthma. There could be other comorbid conditions, or there could be other illnesses that can mimic asthma symptoms. So one of the things is reflux. So every time you have reflux, you have stuff coming up in your mouth, in your throat. And the natural way that the body responds to it is to close up the airway, because it doesn't want those acid and whatever you have there to go into the airway and aspirate. So a lot of times when you have reflux and you have closing of throat and you feel like you can't breathe, it is not asthma. So you need to get the reflux checked. You need to get management of the reflux, and those symptoms will go away. So using an inhaler or using a steroid or any of those things is not going to help it. Other things that can present with wheezing or trouble, feeling that, you're having a subjective feeling of having trouble breathing, are things like vocal cord dysfunction, which happens usually in teenagers that we've seen who are mostly athletes, and they're usually very well conditioned. They can do marathons at a time, but all of a sudden during these episodes, they feel like they can't breathe, their throat is closing, and they have to stop. And it takes them a while to get back to normal, and then the inhalers don't help when these episodes happen. So this is a vocal cord dysfunction in which they have to be retrained to breathe in and out through the vocal cord area, and the symptoms resolve after that. Another entity that we've seen in young adults, again, is exercise-induced laryngeal obstruction, which is another diagnosis that, again, is something not related to asthma itself. And so those things that we have to be careful about not labeling everything as asthma, and getting better evaluations for these as well.
Absolutely. Dr. Khan, thank you so much for joining us.
Sure, it was my pleasure.
And if you at home liked this episode of HealthCasts, please like and comment, and visit smh.com/podcast to listen to more experts like Dr. Khan talking about the health issues which matter to you. As always, we encourage everyone in the community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.